In this video, we are going to discuss about anti-adrenergic drugs or sympatholytic drugs, which are also known as alpha blocker and beta blocker. So, starting our discussion with alpha blocker. In our previous video, we have said that we have two main type of alpha receptor. One is alpha 1 receptor and the second one is alpha 2 receptor. So, there may be three type of alpha blocker. One which will selectively block alpha 1 receptor, and the second one which will selectively block alpha 2 receptor, and the third one which will be non-selective and block both alpha 1 and alpha 2 receptor. Among these three, the selective alpha 2 blocker has no clinical utility, but you can remember the name if you want to, and the name is eohimbine. So, as it has no clinical utility, we will not discuss about selective alpha 2 blocker eohimbine further in this video. So, mainly we have two type of alpha blocker. One is selective alpha 1 blocker and the second one is non-selective alpha blocker, which blocks both alpha 1 and alpha 2 receptor. So, the first point is, what is the common point between these two drugs? The common point is both of them blocks the alpha 1 receptor. And in previous video, we have said that stimulation of alpha 1 receptor leads to vasoconstriction. As it blocks the alpha 1 receptor, so it will block the vasoconstriction effect that will lead to vasodilation. And in which disease we need vasodilation? Yes, we can use this utility in hypertension. So, as both of these drugs blocks alpha 1 receptor, they can be used in hypertension. Now, coming to the difference between these two group of drug, here selective alpha 1 blocker do not blocks the alpha 2 receptor, but non-selective blocks both alpha 1 and alpha 2 receptor. So, selective alpha blocker do not block alpha 2, but non-selective alpha blocker block alpha 2 receptor. So, what is the effect of blocking this alpha 2 receptor? Here a quick recap. In previous video, we have said that this is our alpha 2 receptor which is presynaptically present and it acts as a brake. So, when we push the brake, then it inhibits the release of noradrenaline. So, there is less noradrenaline in the synaptic cleft, and as a result, there is less stimulation of sympathetic nervous system. So, by pressing the brake, we will inhibit the noradrenaline release and we inhibit the stimulation of sympathetic nervous system. So, what will happen if we block the receptor? There will be no inhibition. So, noradrenaline will be released in more quantity in the synapse. Now, what will happen if we use a non-selective alpha blocker? Non-selective alpha blocker blocks both alpha 1 and alpha 2 receptor. So, it will block the alpha 2 receptor here and also the postsynaptic alpha 1 receptor. So, when this alpha 2 is blocked, it will lead to release of more noradrenaline, but this alpha 1 receptor is already blocked and it will act only on this beta 1 receptor. So, stimulation of beta 1 receptor will lead to tachycardia, and when there is tachycardia, it will clinically present as palpitation. So, non-selective alpha blocker leads to palpitation, whereas selective alpha blocker do not have such effect. And the second point, this postsynaptic alpha 2 receptor act like alpha 1 receptor. So, if we block this receptor, there will be more pronounced vasodilation. We can use this utility in severe hypertension. So, non-selective alpha blocker can be used in severe hypertension, whereas selective alpha 1 blocker can be used for mild to moderate hypertension. So now we can discuss about non-selective alpha blocker in details. Non-selective alpha blockers are mainly of two types. One is reversible and the second one is irreversible. What actually meant by reversible? It means it will temporarily block the alpha receptor, so the duration of action will be shorter. But irreversible drug will permanently block the alpha receptor, so the duration of action will be longer. As they are both non-selective alpha blocker, both of them will cause tachycardia. And the drug in reversible group is phentolamine and tolazoline. And the drug in irreversible group is phenoxybenzamine. So what is the clinical use of them? As they are non-selective drug, we previously said that non-selective drugs can be used for severe hypertension. Both of these reversible and irreversible group can be used in severe hypertension. The irreversible group of drug can suppress the severe hypertension and a long-acting drug. So in which condition there is longer severe hypertension? Yes, it is pheochromocytoma. Pheochromocytoma is the tumor of adrenal gland. In previous video, we have discussed in detail about treatment and management of pheochromocytoma. But we can use an alpha blocker only in noradrenaline producing pheochromocytoma. In adrenaline producing pheochromocytoma, the alpha blocker is contraindicated, and the actual mechanism we have discussed in previous video. So phenoxybenzamine is a irreversible group of non-selective alpha blocker and used in noradrenaline producing pheochromocytoma. And in which condition we want to suppress the severe hypertension for short time? The clinical scenario of cheese reaction and clonidine withdrawal. In these two conditions, the blood pressure is severely high that can even lead to death of the patient. So to manage these two conditions, we can use phentolamine and tolazoline. The actual mechanism of these two clinical conditions we will discuss now. First, cheese reaction. In previous video, we have said that cheese contains large amount of tyramine, and tyramine stimulates the sympathetic nervous system in a very severe amount. And this tyramine acts by displacing noradrenaline from the vesicle. A normal person have monoamine oxidase in his gastrointestinal tract. So when cheese taken orally, the tyramine within the cheese is broken down by this monoamine oxidase in the gastrointestinal tract. So no tyramine enters into the circulation and no stimulation of sympathetic nervous system. But a patient with depression taking monoamine oxidase inhibitor drugs will show severe hypertension, as this monoamine oxidase is no more in their gastrointestinal tract. So when they eat cheese, the tyramine within the cheese is not broken down by monoamine oxidase and they are absorbed into the circulation and stimulate the sympathetic nervous system in a very severe range. So the treatment here required is short time suppression of severe hypertension. And we previously said that for short time and severe hypertension, reversible group of non-selective alpha blocker is used, such as phentolamine and tolazolene. So in cheese reaction, the drug of choice is phentolamine or tolazolene. And the second use here is clonidine withdrawal. So what actually happens in clonidine withdrawal? In our previous video, we have discussed in details about how clonidine works. Clonidine actually presses the brake, means stimulate the alpha-2 receptor, and that result in inhibition of release in noradrenaline. As a result, it leads to decreased stimulation of sympathetic nervous system, and as a result, the blood pressure is reduced. Suppose the person had blood pressure of 160, and by using clonidine, the blood pressure reduced to 120. But after the 5 or 6 months treatment, what we have done that we suddenly stopped the clonidine. But during the time of clonidine treatment, as there was no noradrenaline in the synapse, the receptor on the postsynaptic cleft are upregulated. So there is increased number of alpha and beta receptor in the postsynaptic cleft. Now after 4, 5 or 6 months treatment, when we suddenly stopped pressing the brake, there will be release of noradrenaline in the synapse, and now this noradrenaline will act on the increased number of alpha and beta receptor. As it will act on a huge number of receptor, there will be very much severe stimulation of sympathetic nervous system, and this blood pressure now instead of going to 160, it will become suppose 220, and it is a very emergency critical condition, and the person may immediately die. So for the treatment of severe hypertension and for short duration, we want to use phentolamine and tolazolene. So the treatment in a patient with clonidine withdrawal is phentolamine and tolazolene. So we can use this reversible non-selective alpha blocker in Chase reaction and clonidine withdrawal. Now after finishing this non-selective alpha blocker, we will move to selective alpha blockers. Selective alpha blockers mainly act on alpha 1 receptor. Previously, we had said that we have only one selective alpha 2 blockers, and that was yohimbine, which has no clinical use. So we will not discuss about selective alpha 2 blocker. We will only discuss about selective alpha 1 blocker. And the drugs in this group ends with josine. The drug in this group is prazosin, terazosin, doxazosin, and elfujosine. They can be used in various clinical conditions. The first use we will discuss is about benign hyperplasia of prostate or BHP. In previous video, we have said that our prostatic urethra contains alpha 1 receptor, and stimulation of this alpha 1 receptor leads to constriction of this urethral lumen. As a result, there will be urinary retention. So if we block this alpha 1 receptor, there is no constriction of this lumen, and there will be dilation of the urethral lumen, which will help in passing of urine. Now, what actually happens in benign prostatic hyperplasia, we will discuss in details. In benign prostatic hyperplasia, the prostate is enlarged. It is not only enlarged in outside, it is also enlarged inside. As a result, the urethral lumen is narrowed, and that will result in less passing of urine, and there will be urinary retention. So if we block this alpha 1 receptor here, that will lead to dilation of the prostatic urethra, and as a result it will temporarily pass the urine. But in benign prostatic hyperplasia, it has two main components. One is dynamic component and the second one is static component. Now, what actually is dynamic component? The word dynamic here means which is sometimes present and which is sometimes not present. Means the symptoms will be present only when the urine need to be passed. As the prostate is enlarged, the urine cannot pass. So the dynamic component will help only for passing the urine for the time, but it will not reduce the growth of the prostate. So to reduce the dynamic component in benign prostatic hyperplasia, we can use the alpha blocker. But by using alpha blocker, we are providing temporary symptoms relief. We are not treating the growth of the prostate. And the growth of the prostate is here the static component. We know an enzyme in male, that is testosterone. And this testosterone is converted into dihydrotestosterone by an enzyme called 5-alpha reductase. And this dihydrotestosterone stimulates the prostate, and the prostate become enlarged or the growth continues. So if we can inhibit the 5-alpha reductase enzyme, it will decrease the concentration of dihydrotestosterone. As a result, there will be no stimulation of the prostate and the enlarged size of prostate is reversed. So for the static component of benign prostatic hyperplasia, we can use 5-alpha reductase inhibitor. And the drug which inhibits the 5-alpha reductase is finasteride. So for the complete treatment of benign prostatic hyperplasia, we will use alpha blocker such as Josin group of drug and 5-alpha reductase finasteride. Remember, alpha blocker will only provide symptomatic relief, whereas finasteride will reverse the enlargement of prostate, and the treatment of finasteride should be continued even for 4, 5 or 6 months. But there is a problem with this alpha blocker or alpha 1 blocker. The problem is fast dose hypotension. What happens is that if we provide alpha 1 blocker to a patient, it will not only dilate the urethral lumen, it will also dilate the blood vessel. As we said that blood vessel also contains alpha 1 receptor. Blocking alpha 1 receptor leads to vasodilation. So when the vessel is dilated, there will be peripheral pooling of blood. But it is not a problem when a patient lies or in sitting position. But when he stands, this vasodilation lead to more pooling of blood peripherally. As a result, that will lead to decreased blood supply to brain and vestibular system. So the person will lose the balance of himself as the vestibular system is hampered and he will fall. Again, falling is not a very big problem, but if the patient is older and he falls on hard surface, there may be fracture in his skeleton, and that is very difficult to heal. So for preventing this fast dose hypertension, doctors should prefer taking the drug before going to the bed. So the drug should be given at bedtime. What will happen that the person will take the drug and go for bed, and he will not stand, and the blood pressure will not fall, and there will be no fast dose hypotension. So this vasodilatory effect is harmful in a normal person, but we can use this vasodilatory effect in a patient with hypertension. So alpha 1 blocker are useful in patient having hypertension with benign prostatic hyperplasia. It will help in both of these conditions. But in a normal patient, this vasodilatory effect is not required. So what will we do? The doctors have done further research and found out alpha 1 receptor are further divided into two types. One is alpha 1A and one is alpha 1B. The prostatic urethra contains alpha 1 receptor, whereas the alpha 1B receptor is located on blood vessel. Remember, this is B and B stand for blood vessel. So alpha 1B receptor is located on blood vessel and alpha 1A receptor is located on prostatic urethra. So if we can selectively block this alpha 1A receptor, it can be used in benign prostatic hyperplasia without causing the fast dose hypotension side effect. And the drug here is tamsulosin. So in a patient having hypertension with benign prostatic hyperplasia, the alpha 1 blocker such as prazosin, terazosin, doxazosin, alfuzosin, which blocks both alpha 1A and alpha 1B can be used. And in a patient not having hypertension, only alpha 1A blocker tamsulosin can be used. So tamsulosin is a alpha 1A blocker and Josin group of drug blocks both alpha 1A and alpha 1B. So tamsulosin can be used in benign prostatic hyperplasia and Josin group of drug can be used in patient having hypertension with benign prostatic hyperplasia. Now we can use this vasodilatory effect of Josin group of drug in other condition. So Josin group of drug can be used in benign prostatic hyperplasia. Apart from benign prostatic hyperplasia, it can be used in treatment of hypertension. It is a very useful drug compared to other antihypertensive drug because it has beneficial effect on lipid profile. Whereas other antihypertensive drugs such as thiazide or beta blockers worsen the lipid profile condition. So the Josin group of drug can be used in BPH as well as hypertension with beneficial effect on lipid profile. The second use is Raynaud's disease. What is Raynaud's disease? In winter, normal person have vasoconstriction and this vasoconstriction reduce heat loss. And in winter, we need to reduce the heat loss. So this vasoconstriction is helpful in winter. But patients with Raynaud's disease are more sensitive to vasoconstriction. So in winter, they will have more severe vasoconstriction. And this more severe vasoconstriction will lead to ischemia of the peripheral organ like finger of hand and toes. This ischemia will lead to produce lactic acid and that lactic acid will cause pain. As the blood supply is reduced, the redness of the end organ will also be reduced and the organ will look like pale. Here you can see a pale finger. So we can use prazosin group of drug here for the vasodilation. Can we use tamsulosin in this condition? Yes, the answer is no. Tamsulosin is selective alpha 1A blocker and that does not cause vasodilation. So we can only use josin group of drug like prazosin and terazosin in Raynaud's disease. And the third use is scorpion sting. The venom of scorpion is a powerful alpha 1 agonist. So it will lead to stimulation of this alpha 1 receptor, and that will lead to severe vasoconstriction and severe hypertension. So to prevent this, we can use alpha 1 blocker. So there will be no hypertension and the condition is reversed. So we can use josin group of drug here. In fact, josin group of drugs are drug of choice in scorpion sting. So we can use alpha blocker in benign prostatic hyperplasia, in hypertension, in Raynaud's disease, and in scorpion sting. Now, after finishing the alpha blocker, we will move to beta blocker. From our previous video, we know that we have mainly two type of beta receptor. One is beta 1 receptor and the second one is beta 2 receptor. So, beta blockers are maybe of three types. One is non-selective beta blocker, which will block both beta 1 and beta 2, and second one is selective beta 1 blocker, which will only block the beta 1 receptor, and the third one is selective beta 2 blocker, which will selectively block the beta 2 receptor. But we will not further discuss about the selective beta 2 blocker because it has no clinical use. But if you want, you can remember the name, and the name of selective beta 2 blocker is butoxamine. So we have mainly two type of beta blocker. One is non-selective beta blocker and the second one is selective beta 1 blocker. So now coming to the common point and difference between these two drugs. So at first, what is the common point between these two group of drug? The common point is that both of them blocks beta 1 receptor. And we know that beta 1 receptor is situated on heart. So both of them have cardiac indications. And now what is the difference between these two group of drug? Yes, the difference is that the non-selective beta blocker blocks beta 2 receptor, but the selective one does not block the beta 2 receptor. So if we want to block beta 2 receptor, we must use a non-selective beta blocker. So with that basic, we will move further forward. Tell me that in which condition we want to block the beta 2 receptor and in which condition we do not want to block the beta 2 receptor. Remember, heart has only beta 1 receptor. So everywhere else there is beta 2. So if we want to block beta receptor outside the heart, we must use the non-selective one. So the non-selective one has cardiac indication as well as other indication also, but the selective beta 1 has only cardiac indications. So in which condition we want to selectively block the beta 1 receptor? For that we need to revise where the beta 2 receptor is located. The location of beta 2 receptor is on bronchus, blood vessel and liver. In bronchus, if the beta 2 receptor is stimulated, that will lead to bronchodilation. And in blood vessel, if we want to stimulate the beta 2 receptor, that will result in vasodilation. And in liver, if we stimulate the beta 2 receptor, that will reverse the symptoms of hypoglycemia. So now, if we block the beta 2 receptor on bronchus, that will lead to bronchoconstriction instead of bronchodilation. And in asthma, we know that the bronchus is already constricted. So if we block the beta 2 receptor in a person with asthma, that will worsen the asthma condition. Now, if we block the beta 2 receptor on blood vessel, that will lead to vasoconstriction instead of vasodilation, and that will worsen the condition of a person having Raynaud's disease. In Raynaud's disease, we know that the person is already sensitive to vasoconstriction, and if we use beta 2 blocker, that will cause further vasoconstriction, and that will worsen the condition of Raynaud's disease. And if we block the beta 2 receptor on liver, that blocks the reversal of hypoglycemia. So a patient can go to hypoglycemic coma. We know that when the beta 2 receptor on liver is stimulated, that moves the metabolism in such a way that there is production of glucose and the hypoglycemia reversed. And in which patient the hypoglycemia is usually seen? Yes, it is seen in patient with type 2 diabetes. In patient with type 2 diabetes, taking hypoglycemic agent in overdose or missing a meal, that will lead to hypoglycemia usually. And if we block the beta 2 in such patient, the liver cannot reverse the hypoglycemia produced by missing a meal or taking overdose of hypoglycemic drugs, and as a result the person will go to hypoglycemic coma. So if we want to give beta blocker in this patient with asthma or Raynaud's disease or type 2 diabetes mellitus, we must give selective beta 1 blockers. We cannot use a non-selective beta blocker in these patients. So selective beta 1 blocker has only cardiac indication, and non-selective beta blocker has other use also, but contraindicated in patient with asthma, peripheral vascular disease like Raynaud's disease and diabetes mellitus. As the non-selective beta blocker were developed fast, it is called fast generation beta blocker, and the selective beta 1 blocker developed after the development of non-selective one. That's why selective beta 1 blocker is called second generation beta blocker. So now we will move to selective beta 1 blocker or cardioselective beta blocker, which is also called second generation beta blocker. And the name of the drug can be remembered by this mnemonic: new beta blockers act exclusively at myocardium. We can easily see from the mnemonic that the mnemonic is saying that this drug acts only on heart. N stands for nebivolol. B stands for butoxolol. And these B stands for bisoprolol. The AC stands here for asbutolol. E stands here for esmolol, and AT stands here for atenolol. M stands here for metoprolol, and the C stands here for celiprolol. So as this act only on beta 1 receptor, they can be used in asthma, peripheral vascular disease, and patient with diabetes mellitus. If you see carefully, you can see that all beta blockers ends with lol. There are so many of beta blockers. Almost there is 40 beta blockers we have, but only 8 of them are cardioselective and the rest of the drug are not. And you can remember the 8 by this mnemonic. So these are cardioselective beta blocker and they can be used in asthma, peripheral vascular disease and diabetes mellitus. Now we will move to another property of beta blocker, that is intrinsic sympathomimetic activity. We know that sympathomimetic means that it stimulates the sympathetic nervous system. But we are talking about sympatholytic drugs. So is it possible a drug blocks the receptor and as well as stimulates the sympathetic nervous system? Yes, it can only be done in drug having partial agonistic activity. So when a drug is partial agonist, it does not completely block the receptor and does not completely stimulate the receptor. It remains in the middle of them. Now understand this mathematically. Suppose we have 10 beta receptor on heart and each of them can produce a heart rate of 10. So that produces a heart rate of 100. Suppose this person has a cardiac disease and we use beta blocker and the beta blocker blocks two of the beta receptor. Now only there is 8 receptor are available for adrenaline and noradrenaline and these 8 receptor will produce each 10 of heartbeat and total 80 heart rate. So in cardiac disease it reduces the work of the heart by blocking a small portion of receptor. So we can give beta blocker in a normal person without any problem. But the problem is some person are very sensitive or super sensitive to beta blockers. In such kind of patient, the beta blocker blocks almost 70 to 80% of the receptor. That means it almost blocks 7 or 8 receptor out of 10. So now there is only 2 receptor is available for the person and these two will produce each heart rate of 10 and produce 20 heart rate. And this is a condition of severe bradycardia and the person may die because of this severe bradycardia. So is there any test by which we can know that the person is sensitive to beta blocker? No, there is no test still now. So what we can do is that we can give beta blocker and monitor the heart rate. If the heart rate decreases drastically, immediately stop the beta blocker and switch to other safer drug. But if there is no other treatment is available, you must have to give beta blocker. So what you can do now? If you give beta blocker, the person will die due to severe bradycardia. Now here comes the solution and the solution lies in partial agonist. Suppose partial agonist produces heart rate of 5. So now this 8 receptor blocked by partial agonist will produce 8 into 5 means 40 heart rate and the free 2 receptor will produce 2 into 10 is equal to 20 heart rate. So the total heart rate will be 60. So if we use partial agonist, the heart rate will become 60 instead of 20. So in a patient who is sensitive to beta blocker, we can use partial agonist very much safely. And the drugs having intrinsic sympathomimetic activity has the mnemonic contain partial agonistic activity. C stands for celiprolol, P stands for pindolol, A stands for alprenolol and AC stands for asbutolol. So the mnemonic itself saying that contain partial agonistic activity. So celiprolol, pindolol, alprenolol and asbutolol has the intrinsic sympathomimetic activity And what is the advantage? We can use this drug in a patient who is very sensitive to normal beta blockers. And now we will move to our third property of beta blocker, that is membrane stabilizing property. Can you tell me which channel causes depolarization of cell? Yes, it is sodium channel. Sodium channel causes depolarization of cell. So, if we block the sodium channel, there will be no depolarization and the membrane will be stabilized. You also know that the sodium channel is also present on neuron, and if we block the sodium channel on the neuron, that will produce local anesthetic effects. So, membrane stabilizing property or local anesthetic property or sodium channel blocking property all means the same. Now, what is the clinical importance of this membrane stabilizing property? Yes, membrane stabilization is required in arrhythmia. In arrhythmia, the membrane stabilization is destroyed. So, if we can block the sodium channel on heart, that will lead to stabilization of the cardiac condition and that will prevent arrhythmia. So, in treatment of arrhythmia, we can use this membrane stabilizing property of beta blockers. But the another clinical importance is that it is contraindicated in glaucoma. But in our previous video, we have said that stimulation of sympathetic nervous system leads to mydriasis, and if we block it by beta blocker, that will lead to meiosis, and meiosis helps in glaucoma. But why we are saying that a beta blocker with membrane stabilizing property is contraindicated in glaucoma? The other drugs of beta blocker group is used in glaucoma except these membrane stabilizing drugs. But why? What is the actual mechanism? Suppose this is our eye and this is cornea. What is the blood supply of cornea? Can you tell me? Yes, the cornea is a vascular organ. And why we need blood supply? Yes, we need blood supply for nutrition and healing. But this cornea gets its nutrition from aqueous humor. But how it heals? Yes, the cornea does not heal. So, cornea prevents from injury before occurring by a reflex called corneal reflex. When a dust particle or some other object touches the cornea, the extensive sensory supply of cornea sends the signal to the trigeminal nerve, and from trigeminal nerve it goes to brainstem, and from brainstem it passes by facial nerve, and at last the efferent signal comes to the orbicularis oculi muscle. This muscle is a muscle of eyelid. So when the signal comes, the eyelid contracts and the eye closes. So the sensory supply of cornea is saving itself from injury. So if we use membrane stabilizing drug in eye, that will paralyze the sensory supply of the cornea, and as a result there is no afferent signal and no efferent signal and no contraction of the eyelid and no closing of the eye. So as a result the dust particle or some other particle may damage the cornea and which may cause permanent blindness. That's why the beta blocker with membrane stabilizing property are contraindicated in glaucoma. And the drugs in this group you can remember by this mnemonic possess membrane stabilizing or local anesthetic property. The mnemonic is saying here the mechanism of the drug, and here P stands for propanolol, M stands for metoprolol, L stands here for labetalol, A stands here for asbutolol, and P stands here for pindolol. So these 5 drugs having membrane stabilizing property can be used in arrhythmia but contraindicated in glaucoma. Now we will move to our fourth property of beta blocker, that is water solubility. If a drug is water soluble, that cannot enter the brain. As you know that if a drug want to enter the brain, it must to be a lipid soluble drug. So the water soluble beta blocker does not enter into the brain and do not produces CNS side effects. Normally, beta blockers produces CNS side effects such as nightmare, delirium, etc. So the beta blocker having water soluble property do not produces side effects such as nightmare or delirium. But the water soluble beta blockers are contraindicated in renal failure. Water soluble drug can only be excreted from the body by renal route. So if the renal failure occurs, the water soluble drug cannot be excreted from the body. It again comes to the body and produces toxicity. That's why water soluble beta blockers are contraindicated in renal failure. And the drug in this group can be remembered by the mnemonic A and S. A means atenolol, N means nadolol, and S means sotalol. So these three drugs are water soluble and can be used without CNS side effects but contraindicated in renal failure. Now if we come to the fifth property of beta blocker, that is third generation beta blockers. So what is the third generation beta blockers? We have said that the non-selective beta blockers which blocks both beta 1 and beta 2 are first generation, and the beta blocker which selectively blocks beta 1 receptor are second generation. And now we are telling there is also a third generation beta blocker, and the third generation beta blocker blocks the beta receptor and as well as it has some other special activity. The first group of drug in third generation beta blocker, it blocks the beta receptor and additionally it blocks the alpha 1 receptor. And we know that if we block the alpha 1 receptor, that will lead to vasodilation. So these drugs blocks both beta receptor and alpha 1 receptor, and the drugs in this group is levitalol and carvedilol. Second group of drug in third generation beta blocker has nitric oxide releasing property. And we know that the nitric oxide causes vasodilation. So in addition to blocking beta receptor, it also releases nitric oxide that leads to vasodilation, and the drug in this group is nebivolol. The third group of drug here blocks the beta receptor as well as it has calcium channel blocking property. And we know that if we block the calcium channel, that will lead to vasodilation. So this group of drugs blocks the beta receptor and as well as blocks the calcium channel, and the drug in this group is carvedilol. You can see that carvedilol has both alpha 1 blocking property and both calcium channel blocking property. It has one additional property also, antioxidant property. And the fourth group of drug here blocks the beta receptor and also opens the potassium channel. And the drug here is pilosolol. The last group of drug here that blocks the beta 1 receptor but stimulates the beta 2 receptor. And we know that stimulation of beta 2 receptor leads to vasodilation. And the drug in this group is celiprolol. We know that normally beta blocker causes dyslipidemia by blocking the beta 2 receptor on the liver. But this drug celiprolol stimulates the beta 2 receptor on the liver. So these drugs additionally helps in lipid profile. So these are the 5 properties of beta blockers. Now we will move to use of beta blockers. To know the use of beta blockers, you can open the book of pharmacology or any book of medicine, then open the index, see the chapter of CVS and include all the chapter names such as hypertension, angina, myocardial infarction, MI, chronic congestive heart failure and arrhythmia. In all of these conditions, we can use beta blocker, but there are some contraindication in their subset, such as we can use beta blocker in classical angina, but in variant angina, it is contraindicated. As we know that in variant angina, the angina occurs due to vasospasm, and if we block beta blocker, it will provoke the vasospasm more. So we will not use beta blocker in variant angina. We will use it only in classical angina. And beta blocker can only be used in chronic congestive heart failure. We cannot use it in acute congestive heart failure, as in acute congestive heart failure the sympathetic system tries to save the person, but if we block the sympathetic system by blocking the beta receptor, that will worsen the condition of acute congestive heart failure. This These all 5 are cardiac indications of beta blockers, but there are some non-cardiac indications also. In non-cardiac indication, can you tell me which group of beta blocker we will use? Yes, we will use a non-selective beta blocker. And the conditions can be remembered by the mnemonic play the game. Here P stands for performance anxiety or anxiety. We can use beta blockers in anxiety. In anxiety, there is symptoms such as tremors, palpitation, nervousness, etc. If we block the beta receptor, that will lead to decrease in tremor and palpitation. So we can use beta blocker in performance anxiety. We can use beta blocker in thyrotoxicosis. In thyrotoxicosis, we know that the heart rate is excessive due to increased adrenaline and noradrenaline concentration. So we can use beta blocker on heart to get rid of thyrotoxicosis symptoms. We can use beta blocker in glaucoma, but we will avoid the drug having membrane stabilizing activity in glaucoma. Beta blockers can also be used in akathisia. Beta blockers can also be used in migraine prophylaxis. Beta blockers can also be used in essential tremors. Now, after the use, we will move to adverse effect of beta blockers. We know that beta blockers blocks the SA node beta receptor and that decreases the heart rate. So that will lead to bradycardia. So it is contraindicated in sick sinus syndrome. In sick sinus syndrome, the SA node is already sick and cannot produce a minimal heart rate and there is already bradycardia. So we cannot use beta blocker in sick sinus syndrome. The beta blockers also reduces the conduction of heart, so it cannot be used in AV block. It reduces the contractility of heart and we cannot use it in acute congestive heart failure, because in acute congestive heart failure the blood supply to the whole body is already reduced, and if we reduce the contractility, that will endanger the life of the patient by producing shock. And there are some other conditions where we cannot use beta blockers. We said that we cannot use non-selective beta blocker in asthma, peripheral vascular disease like Raynaud's disease and diabetes mellitus. And here we have said that we cannot use it in variant angina. So in variant angina, beta blockers are contraindicated. So that's all about alpha and beta blocker. Thank you for being with me. If you found this video helpful, please do a like, comment and subscribe to my channel.